Sandeep, Dr. Sabu, all. And today I'm going to talk about RSSDI guidelines for the management of hypertension in diabetes. Uh, my only conflict of interest is that this program is arranged by Dexica and Acmedix, but for that there is no conflict of interest. And first disclaimer, in this presentation, I have restricted to the guiding statements made by RSSDI in the paper that I'm going to place next. And I have not extrapolated or reviewed or added any information from the review of literature or guidelines. We may take up during the discussion if required. And only at two or three places, I have just rephrased the statement and would like to have the expert's opinion about that, right? So this is the guideline that appeared in the International Journal of Diabetes in Developing Countries in December 2022 by Dr. Vasant Kumar, Dr. Sanjay Agrawal, Dr. Vansi Sabu, Dr. Breach Makkar, and also there is an extended list of the who's who of RSSDI and India. And what I'm going to talk is, we know that hypertension is a major public health issue and it caused almost about 1.6 million annual deaths, which accounts about 10.8% of the total mortalities and 4.6% of the disability associated living years. In India, about 1/3 of the urban and 1/4 of the rural population have a hypertension. Unfortunately, 50% of them are aware of the same. And very commonly, hypertension and diabetes coexist, especially in the middle and old age group. And people with diabetes have 1.5 to 2 times higher prevalence of hypertension than those without diabetes. Indian hypertension guidelines appeared in 2019, which is in guideline 4, which defines hypertension as a systolic blood pressure of equal to or more than 140 millimeters and diastolic of more than 90 millimeters. While ECC and AHA have now come down to the hypertension cutoff values at 130 and 80, but Indian guidelines still maintain 140, 90 or above. But there is definitely different cutoff for the different settings of the hypertension blood pressure reading. That is, clinical office is same as the Indian hypertension guidelines, but ambulatory blood pressure monitoring, which we now routinely advise whenever there are 1 or 2 readings which are outside the range. So 24-hour average blood pressure of more than 130 or diastolic of more than 80, or a daytime awake blood pressure of more than 135 or 85, or same way home blood pressure monitor of more than 135, 85 calls for the hypertension level. And night time it is more than 120 or more than 70 millimeters diastolic are the readings which will define somebody as hypertension. Now, resistant hypertension is one when the patient is receiving optimum doses of 3 classes of drugs, one of which is diuretic. And when we have ruled out no non-adherence to the treatment in that particular patient, then we should label as resistant hypertension. Resistant hypertension is almost about 10% in the population, and they are at very high risk of cardiovascular disorders, end organ damage, and all-cause mortality. And all patients with resistant hypertension should be screened for secondary causes like whether it's a renovascular, renal hypertension, or aldosteronism, etc. The incidence of resistant hypertension is very common in diabetes than in the hypertension otherwise. And we need to have 1 minute for this relationship between hypertension and diabetes for the adverse outcomes. We know that there are many common risk factors for the pathogenic mechanisms of development of hypertension and diabetes, be it genes, insulin resistance, dyslipidemia, or obesity. All these factors collectively lead to atherosclerosis, which itself can lead to macrovascular disease. And all these factors also produce endothelial dysfunction, vascular inflammations, which we can judge by the elevated CRP levels studied in many studies, then vascular fibrosis and arterial remodeling. These all lead to microvascular disease. So macrovascular disease together will lead to the increased risk of coronary artery disease or cardiovascular diseases. And so why should we treat hypertension aggressively? For the very simple reason that when there is hypertension and diabetes occurs combined in a patient, there are very high chance of all-cause death and CV events, whether it is ischemic heart disease, peripheral heart disease, stroke. Stroke again, whether it is ischemic or hemorrhagic, both are very common in patients with hypertension, diabetes, and cardiac death. Even end organ damage like nephropathy and retinopathy are also very common in hypertension, diabetes. The good part is that treatment of The good part is the treatment of diabetes and hypertension together will definitely yield good results, and controlling hypertension, which is probably easier than controlling diabetes, as we know in practice. So treating hypertension and reducing it by at least 10 millimeters systolic will lead to decreased complications of diabetes in about 12%, associated mortality in 15%, risk of myocardial infarction is reduced by 11%, and microvascular complications by 13%. So it's very, very rewarding compared to controlling only the sugar. We need to control the sugar, blood pressure, as well as the cholesterol. The targets of lowering the blood pressure or as an antihypertensive medicine are less than 140/90. If the non-pharmacological treatment do not bring down the blood pressure to 140/90 or below, we should start with the pharmacotherapy. But the target achieving is by RSSDI, it is suggested that we should try to bring blood pressure systolic to between 120 and 130 and diastolic between 70 and 80. In most patients, if we can achieve it without any side effects of the antihypertensive medicine. And this is very, very important, especially when the patient has hypertension, diabetes, and microalbuminuria to the tune of 70 milligram per kilogram of creatinine. And this slide is on my own, not present in, but this is a total what is mentioned in during the articles that we should need go for baseline investigation in the form of complete blood count, urine analysis, sugar levels, creatinine, urea, electrolytes, especially sodium, potassium, calcium, and phosphorus. When we have PKD in mind, we should need to get the calcium, phosphorus, alkaline phosphorus also. Uric acid is an important marker. Then urinary microalbuminuria, lipid profile, ECG, sonography abdomen, 2D echo, and fundus examinations. At least once we should have all these investigations. Most important is one of them is the urinary albumin creatinine ratio, because we know that this is a very, very important marker of the early diagnosis of CKD and patients with diabetes. And many of these patients, when they are having a microalbuminuria, still they are asymptomatic, and even the GFR may be normal or near normal. So urinary albumin creatinine ratio must be done in all patients, and all these investigations or many of them can be repeated either 6 monthly or yearly depending on the individual case, but at least HbA1c, urinary albumin creatinine ratio, renal functions, potassium, liver functions, and fundus exams are very important. Liver functions for two reasons. One, we give many medicines and statins which may have effect on the liver functions, as well as many of the diabetics also have non-alcoholic fatty liver disease. So LFT, especially the enzymes, hepatic enzymes, should be included at least in a 6 monthly investigation. Non-pharmacological management are the diet, exercise, avoidance of alcohol, tobacco, and ideal body weight. So we know about the DASH studies that dietary adjustment to stop hypertension. But what RSSDI mentions that not all individuals demonstrate a similar rise in the blood pressure when they take salt. So there are people who are salt sensitive, but all said and done, sodium is very, very important cation, which is responsible for many of the pathophysiologic mechanisms of hypertension. There is abnormal handling of the kidneys, there is endothelial dysfunctions, there are immune dysregulations, and because of this sodium and water retention, there is increase in the extracellular compartment and increased cardiac output. All these add to the cardiovascular problems. Then, as far as the exercise is concerned, RSSDI recommends that at least there should be advice for 50 to 60 minutes of 3 to 4 times a week of brisk walking. If a person can achieve more, always welcome. We need to get for them checked up with the cardiologist or a basic test before adhering for any vigorous exercise. Then pharmacological management, of course, of hypertension. We are not going to talk about the diabetes management in this particular talk because the specific topic is management of hypertension in diabetes. So severity of hypertension, if the patient's hypertension is beyond stage 2, then we have to start with the combination therapy. Otherwise, we can start with one drug therapy. And we also need to look for the patient's profile, the ASCVD risk factor. What options we have are ARBs, ACE inhibitors, calcium channel blockers, diuretics, and beta blockers. What RSSDA suggests is that we must start with ARBs, ACE inhibitors first, then calcium channel blocker. If the pressure is very high, maybe we start with the combinations. But diuretics and beta blockers should be reserved for only compelling indications. Then we should be starting. That too, always at the background of ACE inhibitors or calcium channel blockers. So this is one of which is very emphatic recommendation from the RSSDI. And this slide suggests from the RSSDI that we have 4 classes of drugs that we give. Amongst ARBs, RSSDI has come out strongly in favor of telmisartan and quoted many studies which have shown the positive effect of telmisartan. And the second sartan that is to be preferred is escitalopram. This is the first agent, and even in combinations we prefer telmisartans, and amongst calcium channel blocker it is the cilnidipine which is recommended by RSSDI. ACE inhibitors can be used for ARB, but we know that will come in the next slide about the ARB versus ACI, and diuretics, as we have said, should be used in a reserve condition. So amongst ARBs and ACE inhibitors, we know that they are widely used otherwise also in non-diabetic patients also, and they have got similar outcomes, but ARBs are safer, tolerant, and more effective than ACE inhibitors for the blood pressure control and cardiovascular outcomes. And definitely they have less side effects, and they are also renoprotective. Only thing, as I said, that I have taken the liberty to change the word. The RSSDI have used the word telmisartan must be selected as the first line ARB agent in diabetic patients, and that in those who are at high risk, losartan must be preferred. I use the word should, and we'll discuss probably in this discussion time, or when Dr. Sabu is there, we'll like to know the use of word for that reason. But telmisartan is definitely recommended in the patients who have got atrial fibrillation over the other ARBs. ARBs, because they have got a selective 82 receptors, 81 receptors inhibitions, definitely they have an advantage over the ACE inhibitors. Escitalopram has been strongly recommended because of many studies which have suggested that escitalopram has to be preferred in the patients who have got hypertension, diabetes with CKD for its better antiproteinuritic effects. Escitalopram also may be preferred in the patients with hypertension with preserved ejection fraction, which is also one of the very common complications of diabetes. Amongst the calcium channel blockers, we know that all calcium channel blockers have very powerful blood pressure lowering effects and minimum contraindications. And they also reduce CVD morbidity and mortality, and they have got more pronounced effects on the stroke prevention. Amongst calcium channel blockers, RSSDI has come out strongly with cilnidipine because of its novel and unique dihydropyridine calcium channel blocker inhibitory actions, mainly on the N type of calcium channels. All calcium channel blockers, DHP type, have L type channel action, but N type calcium channel effects are seen mainly in cilnidipine. And because of that, normally there is an intracellular calcium overload, which is one of the mechanisms postulated for atrial fibrillation. And cilnidipine restricts this overload and activates the endothelial nitric oxide synthase, which regulates the cardiac function. So cilnidipine has been found to be very, very useful, renoprotective, cardioprotective, and also studies have shown that it also improves insulin sensitivity. So cilnidipine is the preferred molecule by RSSDI as far as the calcium channel blockers are concerned. Amongst the diuretics and beta blockers, as we already mentioned, they should be used only when there are compelling indications, like the diuretics are better with combinations of ARBs and ACIs in resistant hypertension, heart failure, and in elderly patients. While the beta blockers obviously are the initial management of choice for hypertension if the patient also has previous history of cardiovascular disease like myocardial infarction, heart failure, coronary artery disease, or stable angina. What about combinations? The telmisartan and cilnidipine in a single pill combinations have complementary actions and multiple advantages seen in a large-scale studies and meta-analysis. So this is a combination. If the initial pressure is high, RSDI suggests strongly with the combination of telmisartan and cilnidipine. Alternatively, escitalopram with cilnidipine or olmesartan with cilnidipine combinations can also be given because they are also found to be useful. And the last slide about the central aortic pressure. Ever since the CAFE study appeared, the importance of central aortic pressure is known to all of us. And otherwise, routinely we measure the brachial artery pressure, or we call it peripheral artery pressure, for our day-to-day blood pressure monitoring and therapeutic decisions. But central aortic pressure is lower than the brachial aortic pressure, and definitely it is more indicator of the perfusion the coronary arteries, also the carotid circulation. So central aortic pressure measurement is very important, and as I said, after CAFE study, it has found to be having a better predictor of cardiovascular diseases. And we know that antihypertensive medicines can have differential effect on the peripheral blood pressure lowering as well as the central aortic pressure lowering. And ESCOT trials, which were the substrate for the CAFE study, all the volunteers who were in ESCOT trial, some of them were picked up for the CAFE study, and they found that the central aortic pressure was better controlled with calcium channel blockers and ACE inhibitors than the beta blockers and thiazide combination. So maybe that could be one of the reasons to prefer the calcium channel blockers and ACE inhibitors, ARBs, over the beta blockers or thiazide. So summarizing, hypertension and diabetes frequently coexist in middle and old age. Patients of diabetes have 1.5 to 2 times higher prevalence of hypertension than without diabetes. Indian guidelines still maintain the labeling of hypertension as a blood pressure of more than 140 or 90, and the recommendation of bringing down the blood pressure as a target, therapeutic target, is 120 to 130 systolic and 70 to 80 diastolic, if we can achieve it without the side effects of the antihypertensive medicines, and more so if the patient also has diabetes, hypertension, and CKD with albuminuria. The non-pharmacological management have their role, but what is important is that most of the patients would need the pharmacological management, where ARB or ACE inhibitors are the drug of choice, and calcium channel blockers may be added in combination with the ACE inhibitors or ARBs, and beta blockers and thiazides are required to be used when there are compelling indicators. Thank you.
Thank you, Mahadev bhai. It was very good. And I think everything very precise, which drug to use and which combination to use in patients of diabetes. And I think we should move on, or we want discussion right now, or we should move on to the next topic.
We'll be having panel discussion at the end. If okay. Dr. Bansi is there or Bansi has reached the destination, then we will tell him to, because he was on the way, so we have not involved him in welcoming or the designing of this program. I think Bansi is still not there. So Dr. Kamal Sharma has joined. I don't think Dr. Kamal Sharma is there. So we will be inviting our third speaker, that is for dyslipidemia management and consensus statement. Yeah, so we will move on to Dr. Sanjeev Phatak, sir. I think we all know Dr. Sanjeev Phatak. He is a clinician par excellence, academician, researcher, and he is like a mentor to many of us. He keeps on guiding us to do better, not only in clinical practice, but also in life. And I will invite him to speak on dyslipidemia management in diabetes, RSSDA consensus statement. Over to you, Sanjeev.
Good evening, and thank you, Dr. Pratap Jethwani. Thank you for giving me this opportunity, and thank you for your over-generous introduction. But anyway, thank you very much for that. After a very precise talk by our senior Dr. Mahadev Desai regarding the management of hypertension in diabetes, I'll take the next topic, that is dyslipidemia management in type 2 diabetes, rather diabetes itself. What do the RSSDI guidelines suggest, and what is new in 2023? As Dr. Mahadev bhai rightly pointed out at the beginning of the talk, that whatever I am going to present are not my views, not anyone's views, but the RSSDI guidelines. Okay, so the may I be able to share my screen? So is my screen visible?
Yes, it is visible.
All right. Just a minute. Is it in the full screen mode, slideshow mode?
Oh, no.
No, sir. No, sir.
Not yet?
No, I think you need to reshare it.
Okay, so I'll stop sharing. Share it again.
Better if you keep it in.
Now?
Yeah.
It is.
All right. Okay.
Absolutely.
Yes.
Perfect. Yeah.
Yes.
So what is new in 2023 in the RSSDI guidelines for dyslipidemia management in diabetic patients? That's what I'll be talking about. My disclosures, as Dr. Madhavbhai also pointed out, that this is a Acmedix pharma sponsored program. Otherwise, whatever I'll be talking about today is the RSSDI guidelines. Okay. The author expert committee for this dyslipidemia management includes Dr. Vasant Kumar, Dr. Sanjay Agrawal, Dr. Bansi Sabu, and Dr. Pratap Jethwani also. And we are honored to be on the same platform as Dr. Bansi and Dr. Pratap are here because in their presence, the guidelines was this guideline was written. I'm talking about the dyslipidemia guidelines. We know that the diabetic dyslipidemia is characterized by low HDL and high TG levels. Unlike the Caucasian, our LDL levels are not very high, and in spite of that, a lot of us develop coronary artery disease and the atherosclerotic events. There is a preponderance for more atherogenic, small, dense LDL particles amongst us. Furthermore, the ApoB levels are also elevated, and this unique atherogenic dyslipidemia, which consists of high TG, low HDL, borderline elevated LDL, high amount of small dense LDL, and ApoB makes it unique for our South Asians. And that too, coupled with high lipoprotein A, increases our cardiovascular risk very, very significantly. So irrespective of other risk factors as age, male gender, hypertension, family history, smoking, obesity, PCOS, we all must screen all our diabetic patients for regular lipid levels, at least once in a year or when on treatment once in 6 months. The recent data from the National Family Health Survey, which was a cross-sectional survey of 29 Indian states and 7 Indian territories, and it estimated the prevalence of undiagnosed diabetes in India, that they identified 42% of their population with diabetes was undiagnosed with poor detection rates. And because of this, we have very high prevalence of micro and macrovascular complications. Moreover, of those who are detected to have diabetes, they are not optimally treated, and more than 75% of them still remain uncontrolled. And there are a lot many complexities in the management of glucose. But compared to that, if you treat the dyslipidemia aggressively, it is very easy to treat. It is very easy to achieve the target. And that is the most effective way of reducing the cardiovascular event rate. So coming back to the atherogenic dyslipidemia, in the cross-sectional study, the Indian diabetic patients, the prevalence of atherogenic dyslipidemia was 34%, 73% of whom had high HbA1c levels. And in the studies, the authors also observed a staggering 89% of the patients with newly diagnosed diabetes had high prevalence of dyslipidemia. Moreover, the concentrations of lipoprotein small a also were found very high in our diabetic patients, and that also was accountable for increased cardiovascular risk, increased peripheral arterial disease risk, aortic valve stenosis, heart failure, and reducing the lifespan as well. So there is a definite need to screen for dyslipidemia in diabetes, and the RSSDI advocates simultaneous screening and treatment for modifiable risk factors for CVD like dyslipidemia, hypertension, alcohol consumption, smoking cessation, not only in people with diabetes, but also in people with pre-diabetes. Because we know that the risk of coronary artery disease starts much before the clinical onset of diabetes. And that is why at the pre-diabetes level also, we should be aggressively targeting all these cardiovascular disease risk factors. In patients with diabetes, the dyslipidemia should be assessed at diagnosis and annually thereafter, and periodic screening is recommended in overweight or obese people, children with family history of type 2 diabetes, or those from a predisposed race or ethnicity like Asians or American Indians, or Indians living outside India. They are at even more risk compared to Indians living in India. When to do the lipid profile? Now, this is very important point that nowadays, with the current methods of estimating the LDL, we do not need a fasting sample always. Though the fasting sample is gold standard for atherogenic risk assessment, it is highly sensitive to detect the triglyceride levels, especially in patients with insulin resistance, and it is preferable in certain high-risk people or when triglyceride is more than 440. Actually, these days, most of the times, the non-fasting lipid levels are considered very appropriate because it can detect the lipid levels of both atherogenic lipoproteins of hepatic descent as well as those originating from the intestines. Because if you are not fasting, the food also can contribute to the triglyceride, and that is why you can know the postprandial increase of the triglyceride. So it can detect both hepatic as well as intestinal contribution to the lipids. It is also preferred in patients with diabetes due to increased risk of hypoglycemia due to fasting. And the LDL cholesterol with the modern techniques, there is hardly any difference whether you do in the fasting sample or non-fasting sample. Only for the triglyceride, it can sometimes be 20 to 30% higher, but otherwise, all other lipid levels are not altered whether the person is fasting or not. And very importantly, it reduces the patient barrier to testing. Whenever the patient has come to you as a walk-in patient, you can test the lipid profile and decide the dose of the statin that the patient will require. Now, before moving on to the pharmacological management of dyslipidemia, yoga also plays a very important role, and the authors of the RSSDI guidelines concluded that the implementation of yoga significantly mitigates the hyperlipidemic states in patients with diabetes. Moreover, the authors also reported an association between greater optimism with greater HDL and lower triglyceride, and no significant association with LDL or cholesterol with sleep optimism. So adequate sleep is also an important factor for HDL and triglyceride, not that much for LDL or total cholesterol. Medical nutrition therapy also plays an important role, like it plays a role in diabetes and hypertension management. Carbohydrates need to be restricted, especially in patients with obesity and in patients with hypertriglyceridemia. Fats, not more than 30%, saturated less than 10%. High amount of monounsaturated fat should be given. Saturated should be restricted to less than 10%. And obviously avoiding the hydrogenated vegetable oils and recurrent frying, and that will also play an important role in the dyslipidemia management. Protein should be liberal, 15 to 25%, depending upon the renal status, of course. So the RSSDI ASI guidelines give a very important role to the medical nutrition therapy. They advocate a diet rich in fruits, leafy vegetables, nuts, fibers, whole grains, like that, and low-fat dairy, of course. We know that the wheat has now been publicized or emerged as a single largest contributor to the nationwide obesity. And that is why the carbohydrate content or the wheat content or the rice content should be restricted so as to avoid hypertriglyceridemia, obesity, and uncontrolled glycemia. Coming on to the statin, which is the most important part in the dyslipidemia management. Statin therapy is indicated not only in patients with genetic causes of dyslipidemia, but also in primary and secondary prevention of ASCVD, regardless of the LDL levels. Moreover, usage of statin in high-risk individuals like those with diabetes duration of more than 40 years and high-risk primary prevention is generally accepted to offer significant benefits. The recent ADA recommendations are also in concurrence with those of AHA, And for primary prevention, moderate intensity statin therapy with lifestyle. And for established cardiovascular disease, high intensity statin is usually recommended. A recent multi-center open label study by Lee et al. Of 134 patients with diabetes also showed the role of ezetimibe 10 milligram compared to statin alone. Ezetimibe plus statin gives much better LDL reduction, much better ApoB versus A1 reduction. So ApoB versus ApoA1 ratio is very, very significantly altered by the statin ezetimibe combination compared to the statin monotherapy. So now ezetimibe has also come into play, and RSSDI, I'm very happy to say that, has given due importance to the ezetimibe role. Whereas most of the other guidelines still do not give a significant importance to ezetimibe. Though we know that it is a very safe drug, very efficacious for reducing the LDL. Coming on to the new molecule, that is bempedoic acid, and it is a small molecule ATP citrate ligase inhibitor and being developed as a once daily first-in-class oral drug. And the clear outcome study, which was recently published, the interim results, have shown cardiovascular benefits in these statin intolerant patients. But in addition to statin also, when statin ezetimibe cannot achieve the target, we have seen that addition of bempedoic acid is very effective in reducing the LDL levels. So bempedoic acid lacks the muscle-related or the myalgia side effect of statin, but they are also associated with some increase in the uric acid level or even sometimes tendon injury. So that is why bempedoic acid, though effective, is still a new drug and should be used only in people who are intolerant to statins. We also have an alternative to statin when the statin is not tolerated, that is PCSK9 inhibitors, and we have both evolocumab and evolocumab available, and these drugs have shown promising results in the studies. The treatment with the PCSK9 inhibitors in diabetic people is associated with reduction in the cardiovascular risk, and that is why they are also recommended by the national guidelines as well as the international guidelines when patients are not able to tolerate statin or when statin alone is not sufficient. For statin intolerance patients, we also have an option of reducing the statin dose and adding a fibrate, though there is no evidence at present to suggest that fibrates can reduce the cardiovascular risk significantly, though some of the studies like DACE showed significant reduction of the triglyceride level with fenofibrate also reduced the cardiovascular mortality. But at present, we do not have a very strong evidence in favor of fibrates for reducing the cardiovascular event rate. Same is true for saroglitazar, though it is a very effective drug for reducing the triglyceride and may have some benefit in NAFLD, but at present for cardiovascular risk reduction, these drugs are not indicated. In special populations, type 1 diabetes, pediatrics, definitely if the patient has familial hyperlipidemia or when the LDL is very high, or if type 1 diabetic people are having LDL of more than 160, definitely statins are indicated. Statins, though there are some safety studies in pregnancy, at present they are contraindicated in pregnancy or in women who are expecting or are planning to become pregnant. In elderly, definitely statins are indicated. Higher the age, higher is the risk. So unless there is a contraindication for its use, one should not avoid statin. Even in hepatic conditions, of course, with end-stage liver failure, statins may not be used, but otherwise they are very safe as far as the hepatic conditions are concerned. And in the renal impairment also, even in the end-stage renal disease, statins can be given. Some prefer atorvastatin compared to rosuvastatin, but at present, the evidence is similar for both the statins. So finally, coming on to the stepwise management of Indian patients with dyslipidemia. First, stratify the risk for ASCVD. If age is less than 40, and if the ASCVD risk is moderate, you may need moderate intensity statin, or even sometimes without statin also, one can do. But if the age is more than 40, you will need a very good statin. If the person is high risk, you will need a high intensity statin. So you decide the risk based upon the ASCVD score, or even you can use the Q-risk tool, which we commonly use, because ASCVD for our Indian patients probably underestimates the cardiovascular risk. Compared to that, Q-risk 3 is probably better because it also includes chronic kidney disease. It also includes the presence of other inflammatory conditions like rheumatoid arthritis. It also gives due importance to the family history of atherosclerotic vascular disease. And that is why I think that Q-risk may be better. Set the lipid goals as per the ASCVD risk. The LDL goals for patients who are moderate risk, then the baseline to less than 30% reduction. High risk, less than 50% reduction, or rather 50% reduction, or LDL of less than 70. And if the person is very high risk, then you target LDL of less than 50 or almost equivalent to HDL. So if your HDL is 40, your LDL should be 40. In other words, the ratio of LDL to HDL should be close to 1 and not more than 1. The triglycerides, the general target is 150 or below. LDL, the statins are the most efficacious and time-tested agents. And if you require a moderate intensity statin, you have different options. Atorvastatin 10 to 20, Rozua 5 to 10, Simva 20 to 40, Pitava 2 to 4. I'll not go into discussion about the others. The high intensity statin, we have only two options, Rozua 20 to 40 or Atorva 40 to 80. When the goals are not met with the highest tolerable dose of statins, then you have an option of adding ezetimibe. Now you also have an option of bempedoic acid. It is not there in this guideline because the guidelines were written before the clear outcome study, I believe. And you also have the option of PCSK9 inhibitors. For triglyceride reduction, still statins comes first. But if the triglycerides are very high, say more than 500, you may need fibrate or saroglitazole or even omega-3 fatty acids. So with this, I'll stop here. Thank you very much for your very kind audience. And if there are any questions, I think we can discuss them at the panel discussion. I'll stop sharing and it's over to you, Dr. Jethwani.
Thank you, Dr. Sanjeev Pathak, sir, for that very brief overview of dyslipidemia management in diabetes, what RSSDI says. So now I will invite Dr. Kamal Sharma for heart failure in diabetes RSSDI consensus statement. You all know Dr. Kamal Sharma was the leading cardiologist, interventional cardiologist at City of Ahmedabad. He is attached with Sal Hospital, UN Mehta Institute of Cardiology. One new thing which I learned today is that he is only cardiologist who have cleared civil services exam also in first attempt. And he has also been awarded Excellence Teacher Award by Gujarat University. We all know that he is a very good author and he has published many books which are very popular among undergraduate and postgraduate students as far as cardiology and clinical medicine is concerned. So I will invite Dr. Kamal Sharma to speak about RSSDI consensus statement on heart failure in diabetes.
Good evening, everyone. Thank you. I hope my slides are visible.
Yes.
Yeah. So thank you for the opportunity to the kind introduction, chairpersons, my fellow friends, RSSDI and Acmedix for allowing me for this meeting. Let's go ahead to the first slide. So I want to first primarily thank the authors who are Dr. Bansi and team. We have the eminent panel here. So what's new in 2023 is what I'm going to touch upon. So type 2 diabetes is a risk factor itself for causing heart failure. And pathophysiologically, the two conditions are very much linked. So it's like if you have diabetes, you can develop heart failure. And if you have heart failure, you can develop diabetes. That's how timely identification and identifying and intervening in both of them is important to prevent the occurrence of the other one. Next slide, please. So we know that in one of the Swedish studies where they looked at the Spanish as well as the Spanish as well as the Swedish heart failure registry data, the prevalence of type 2 diabetes in patients with heart failure is ranging from 1/4 of the patients to 1/2 of the patients of the total population. That is 24% and 45%. And so they had a 15% prevalence of heart failure and almost similar prevalence of angina. And remember, 10% of MI in patients with type 2 diabetes also had the same. Next slide. So the A1C, as we know, one of the favorite tools of assessing the overall scenario for positioning the severity and chronicity and time in range beyond the fasting and PPBS we look at is A1C. The variability in A1C is another important methodology which has been postulated that it will augment the cell apoptosis and oxidative stress, and it itself can lead to heart failure. And hence, CKD increases mortality, so does the progression of CVD as well as heart failure itself. Next slide, please. So this India B study, which is the one of the biggest study done by the ICMR itself, and then this has looked primarily into the cardiac abnormality which are associated with asymptomatic diabetes mellitus, including LV diastolic dysfunction and other modifiable risk factors for heart failure which are coexisting with diabetes, which have been identified as obesity, coronary artery disease, hypertension, anemia, and very importantly, obstructive sleep apnea. So the later two are very under-evaluated and often missed in management of heart failure as well as in patients who have diabetes. So in a patient of diabetes, you should always look at and suspect aggressively presence of underlying comorbidities and risk factor, which should include evaluation for anemia and obstructive sleep apnea. Next slide, please. So the key home messages are that approximately half the patients of chronic heart failure in India have diabetes, and the rate of heart failure in India is expected to increase by 18% annually. And hence, it's important that in such a chronic disease, just like diabetes, you need early diagnosis and therapeutic intervention to improve morbidity as well as mortality, because most of the patients who have diabetes are ultimately going to die of CV outcomes, which includes heart failure as one of the important modality by which the patient suffers and dies. Next slide. So again, in the study where they looked at is the in the correlation between left ventricular hypertrophy and type 2 diabetes, and hyperglycemia that was present was associated not only with insulin resistance, and this also led to hyperglycemia being responsible for reduction in the rate of heart failure if that was treated adequately type 2 diabetes. So diabetic cardiomyopathy, as we know, is an independent of atherosclerotic ischemia. You can have patients who don't have coronary obstructive artery disease, but they have a bad LV dysfunction, systolic dysfunction. And a lot of these patients also have a HFpEF, which is heart failure with preserved ejection fraction. And we now know how the SGLT2 inhibitors improve both of these outcomes, irrespective of diabetes, and also in patients with diabetes itself. Next slide, please. So the prevalence of heart failure based on ejection fraction, as we were discussing, of HFrEF and HFpEF in India is almost similar. 50% of the patients have HFpEF, 50% of them would have HFrEF. You can otherwise also say that there is another subgroup, like one third have either, and then there is another one third which have both. So heart failure phenotype and the stage of heart failure identification can guide the management. And nevertheless, in spite of no specific treatment, as we know, beyond the SGLT2, which has just opened the foray of managing the same, it's important to distinguish HFrEF from HFpEF so that you can efficiently do the risk factor modification and also prevent the disease progression. Next slide. Also, the consensus recommendation is that the ESC guidelines suggest that in patients with type 2 diabetes with heart failure, metformin is not only safe and is first line for glycemic control, but it is also associated with better short-term and long-term prognosis. And now the Carolina trial has, after evaluating the CV outcomes, has shown no increase in the risk of heart failure hospitalization with glimepiride also in type 2 diabetes without heart failure. Next slide. But of course, the most important point that remains is the SGLT2, which remains an important pillar. Also, it's important to realize that reports on effect of thiazolidinediones and CV safety are conflicting. There have been meta-analysis of increased risk of MI with rosiglitazone, and because of associated side effects like fluid retention and weight gain, and especially in patients class 3 or 4, you must avoid this in patients with heart failure. Next slide. The GLP-1 have shown benefit compared to placebo in decreasing the composite CV outcomes. We know this was first signal was in leaders, and this has been now further strengthened by a lot of other trials with this GLP-1 analogs. We know that from Rewind, we know that from signals coming from Pioneer 6. And so GLP-1 analogs have been preferred therapy after metformin in type 2 diabetes if they have established a CV disease. And there are ongoing trials to further understand the CV benefits, both in acute phase and patients as apart from the chronic patients of heart failure with reduced ejection fraction. Next slide. So, of course, the certain gliptins like sexagliptin and even allogliptin, they have increased the risk of heart failure hospitalization. We know that from the sexagliptin severity trial. We also know that from the Examine trial, and hence that's why you need to be choosing DPP4s with good clinical judgment based on the evidence that is around each molecule. So the preferred would be to use linagliptin or maybe sitagliptin, and to some extent maybe we can use vildagliptin, but not surely sexagliptin or allogliptin. Next slide. So vildagliptin, there's a big trial called Vivid trial, which has demonstrated no improvement or a major detrimental effect in ejection fraction. It caused a significant increase in LV volume, especially end-diastolic volumes by 17 milliliters, and with a good confidence interval of 4.6 to 29 with p-value significant. And so was the case with end-systolic volume rising by 9.4 ml. Next slide. Now, coming to the most important aspects, the SGLT2 inhibitors, as I was mentioning, they have been very promising. They have shown very clear-cut benefit across the class, how they are beneficial in reducing heart failure hospitalization as a class effect. We have different outcomes in patients with regards to the CV outcomes, but all across the class, including the Vertus CV, which evaluated ertugliflozin, which was supposed to be a negative trial. But even there, we had good enough evidence to suggest reduction in heart failure hospitalization. So in patients who have HFrEF or stable heart failure with mid-range ejection fraction also, SGLT2 not only are safe, but there is clear evidence to use that in patients with diabetes mellitus in stable heart failure as well. Next slide. So the consensus US FDA guideline the FDA has approved dapagliflozin for adult patients with reduced ejection fraction to reduce the risk of CV death and heart failure hospitalization. And so dapagliflozin is the first among SGLT2 inhibitors which is approved to treat adults with MIH class 2 to 4 with HFrEF. And also that dapagliflozin has shown improvement not only in heart failure hospitalization, but also in survival in patients with HFrEF. So safety effectiveness of data is to be evaluated in randomized double-blind placebo-controlled trial of 4,744 patients in DAPA-HF trial. And the average age of this study was 66 years, with 77% patients being male. And the results were so promising even at 18 months that patients who were on DAPA had fewer CV deaths, heart failure hospitalization, and urgent heart failure hospitalization visits as compared to the placebo arm, establishing the therapy across the spectrum of heart failure, irrespective of diabetes mellitus. Next slide. Also, the many patients who have added comorbidities, including heart failure, may require addition of insulin for glycemic control. So CVOT with long-acting insulin analogs do not demonstrate increased heart failure hospitalization. And also, the evidence to support the safety of insulin use in patients with type 2 diabetes with heart failure is also not very clearly established. But however, glycemic control is an important aspect, and this would require judicious use of insulin in patients with diabetes with heart failure. Next slide. Now we know Arni, sacubitril valsartan, which is used in heart failure from the paradigm HF, which blocks the action of angiotensin 2, which is harmful in patients with heart failure by blocking the receptor of angiotensin 2 by the valsartan, and the sacubitril salt being the additional benefit that it achieves by dual action. And this effect stops the harmful effect that can ensue, and it allows blood vessels to dilate, reduce the systemic vascular resistance, and reduce the afterload in patients with heart failure. Next slide. So Nelpressin inhibition is also mediating the dilatation apart from the inhibition of ARB action through the valsartan. So the guideline recommendation from the consensus point of view is use of RAS inhibitors exhibiting similar efficacy in heart failure irrespective of diabetic patients, and ACE inhibitors, they contribute to the reduction of all-cause mortality. As the choice between the sacubitril valsartan versus ramipril in heart failure, by the consensus states that you can use either, but now we have strong evidences emerging for ARMY with regards to the initiation of this therapy for patients who are already on ACE or ARB to be switched as class 1 recommendation by the ESC. Next slide. Beta blockers, they have shown with good safety, equivocal safety profile, both in diabetic and non-diabetic patients. However, they can aggravate the hypoglycemic events unawareness. By themselves may not cause hypoglycemia, but glycemic unawareness is one of the big issues because it inhibits the sympathetic counter-regulatory response that a patient with hypoglycemia may develop, which can be blunted by non-selective beta blockers. Ivabradine is recommended in heart failure in patients who are symptomatic despite the classical 4 pillars and have sinus rhythm and heart rate more than 70. Next slide. The therapeutic targets in diabetes, apart from the SGLT2, now have been novel targets, include the ongoing trials for patients with heart failure with reduced as well as preserved ejection fraction, which includes ularitide, which is a synthetic analog of ureladiolintine, which is investigated already in phase 1 and 2. It's a renal peptide, which causes diuresis, vasodilatation, inhibits the RAS by binding to the natriuretic peptide receptor NPRA1, though this has not been shown yet to be superior, but this is an additional pathway which can be targeted in patients with heart failure and is being evaluated in phase 3 trials. Next slide. Levosimendan is an inotrope which has got additional calcium action of vasodilatation and protection against ischemic and reperfusion injury. It increases the cardiac contractility. PD5 inhibitors, which are typically principally used in management of pulmonary arterial hypertension, they have shown benefits in heart failure with reduced ejection fraction, but not so beneficial in preserved ejection fraction. But new drug that has come off late very strongly in trials called Galactic trial, and also now the Cosmic HF, which was the phase 2. The Galactic HF was phase 3, with the omective mecarbil, which is a cardiac myosin activator, which improves cardiac contractility. And this is very promising, and it's now an approved therapy in patients with refractory heart failure in US. Next slide. Also, we have patients with ATTR type of cardiac amyloid, where they usually present first with HFpEF, and then they may end up with HFrEF. For them, tafamidis is used as a transthyretin amyloid cardiomyopathy management by binding the thyroxine binding sites of transthyretin, and it has demonstrated a reduction in amyloid cardiomyopathy related CV hospitalization. Inflammation, the missing link, as has been proposed and talked about, is being modulated and managed by canakinumab, which is an anti-inflammatory monoclonal antibody targeting interleukin-1 beta, and is shown to a dose-dependent reduction in heart failure hospitalization in patients with previous MI, especially if they have elevated hsCRP on initiation. Next slide. So the algorithm for management of heart failure in type 2 diabetes would go something like this, and this is what is being proposed. Clinical signs and symptoms of heart failure, we will get a blood test, X-ray, ECG, you rule out a differentials like anemia CKD, look at for an angiogram, suspect a heart failure, look for the biomarkers like NT-proBNP or BNP, confirm the diagnosis, and then you can say to transesophageal or stress echo if required. Next slide. So once this diagnosis is confirmed based on the algorithm that we are proposing, you need to look at in diabetic patients the hyperinsulinemia, hyperglycemia, also presence of AGE deposition, dyslipidemia, inflammatory response, which all can be mediated and modulated and treated as a potential site of therapeutic response with activation of RAS, mitochondrial dysfunction, oxidative stress, and autonomic neuropathy with endothelial dysfunction, atherosclerosis, and ischemia causing the diastolic dysfunction or mitochondrial dysfunction, which can present with mirrored responses like HFrEF, HFpEF, or HFmEF. So mid-range preserved or reduced ejection fraction. Next slide. So once the patient comes to you with a heart failure, you have put the patient on diuretic. Now, a lot of times we put on SGLT2. Your choice would be to maximal tolerated beta blocker and ACE, ARB, or ARNI. And if that's the case, the patient is ejection fraction less than 35, class 2 or above. You would switch to ARNI in patients who are, even if they are stable and symptomatic on less than 35, and you look at the QRS duration, if the white QRS is there, the choice would be CRT and doing a synchronization therapy. If not, and the heart rate is more than 70, you can choose ivabradine to be added. If there is resistant hypertension, you can consider LVAD or heart transplant. Of course, there is evidence-based management before the comorbidities like ischemic heart disease or coronary artery disease, atrial fibrillation, COPD, CKD, anemia, or OSA, which need to be addressed separately for individual cases also. Next slide. So that brings me to the end, and I hand over the session to the chairpersons. Thank you very much for having me to present the consensus document for heart failure management. Thank you.
Thank you, Dr. Kamal Sharma. And I think now we will move on to the panel discussion related to all these three guidelines. I will invite Dr. Jimit, Dr. Bansi, if he is there. Dr. Bansi? I think Dr. Bansi is there. And if any participant has any question, please post in chat group, and I will request Acmedix team to communicate us those questions. So let me start by asking first question to Dr. Kamal Sharma. In a routine clinical practice, because most of our diabetic patients, they've got some kind of history of easy fatigability. How can we differentiate it whether this patient is having heart failure or not? Is there any clinical risk score or something like that that will give you a hint that this patient should be subjected to further testing for heart failure? Because we cannot subject each and every patient for echo or biomarkers, they are costly.
Good question. I think we have a lot of Framingham heart risk score assessments, and there are some other clinical scores that are available which you can utilize. But in our practice, a lot of times the echocardiography is utilized much ahead of biomarkers. That's the problem, or I would say maybe that's the cost effectiveness tool that we people have approached. You know, it's much easier for a patient to get an echo in a trust hospital at a rate which is much cheaper than the cost of NT-proBNP in the same trust hospital. So I think the way the costs have played its role in choosing biomarkers later on rather than as the first point of diagnostic contact, as the most of our algorithms talk about, has been positioned in these terms primarily because of the cost effectiveness of these tools in our part of the world. But as the cost of NT-proBNP and proBNP starts coming down, which it is doing, and there are other point of care devices which are coming in, I think the same simultaneous assessment of both echo and NT-proBNP would come and play a big role. But your point is very much valid. We have a lot of clinical assessment scoring systems available, including the Framinghams, which can easily be used. And it's simple. If you have a patient who's got raised JVP, a Gallup, a CRAPS, PND, exertional dyspnea, which is very simple, major and minor criteria, as we remember. And there are some new scoring systems which have been proposed, but I think none of them is as strong or robust as a biomarker or an echocardiography. When you're in doubt, you should always go ahead and fix with either or both of them.
Thank you. I think Dr. Bansi is there. Bansi, are you there? Would you like to comment about all the three lectures and all the three guidelines by RSSDI? Dr. Bansi, are you there?
Yes, I am there. First of all, I am congratulating Pratap and RSSDI Gujarat team for doing this meeting, because it's very important. In 2022, we have come out with the three guidelines, very important guidelines, which is done by RSSDI on hypertension, dyslipidemia, and heart failure. Now, we know many of our clinicians and physicians, they are following Western guideline, even though our guideline may not be different. But what we had done in 2022, that, comprehensively a guideline which is made for Indian clinicians, primarily for a primary care physician, and which is done by RSSDA. So I congratulate here RSSDA Gujarat chapter to, increasing the awareness about the Indian guidelines, which are there already in with RSSDI. And again, thanking the Acmedix and Ajay Kumar for bringing out very important topic. Once again, congratulations to Dr. Mahadev Bhai, Sanjeev Pathak, and Kamal Sharma for very fantastic talk. And in a panel discussion, one very important thing, because somebody may ask you that what difference which we have done in our guideline in compared to international context. The one confusion was always there with the hypertension. There was a constantly guideline which was changing with JNC and with European Society of Cardiology and then International Society of Hypertension. There was always, some minor differences was there. So which we tried to do in our RSSDA guideline. The same was for dyslipidemia. There is an International Atherosclerotic Society guideline. There is an ACC guideline. There is an ESC guideline. And for heart failure also, ESC, ESD, ADA, and many more international organizations have done the guidelines. So there are some minor differences. Those who want the full printout of this guideline, they can visit our website of RSSDA as well as our journal IJDCC, and they can download these guidelines. But today's talk, which is done in a very PowerPoint presentation, will give you the complete summary of all these guidelines. And I hope that Pratap will keep these recorded lecture, or the RX event can keep these recorded lecture. And even that can be also widely circulated to all the doctors. Even it can be on YouTube too. So if anybody wants to listen later on, if they are not, listening today, they can still go on and they can listen this talk. In future, we can also do the Facebook Live of the same, these important topics, which can be there. So anyone can listen later on also. With this, once again, thank you and congratulations both Pratap and the RSDA Gujarat team. Thank you.
For that encouraging remarks. And now I will request Dr. Sandeep and Dr. Jimmy. There is one question, Dr. Sanjeev Pathak, sir, that is related to dyslipidemia. There are two questions. First is it rational to add bempedoic acid to statin? I think all three speakers can join in. Reason one, there is no trial so far where both drugs are used simultaneously and showing that they are efficacious and they are having cardiovascular benefits. And second, both have action on similar pathway. So what are your comments, Dr. Pathak, sir?
Yes, I think it's a very good question because both the drugs act through the similar pathway. Bempedoic acid works one pathway above statins, that is before the HMG-CoA detectors pathway. But still, I think one of the clear studies has combined statin with bempedoic. Though the studies are small, but it is not that there are no studies. Of course, having said that, addition of bempedoic acid to statin, one should be careful. Though the muscle concentration is not achieved for bempedoic acid, the tendon injury is reported, and that is why one has to be more careful. In a period of time, I think some of the studies will emerge, but at present, most of the studies are, as you rightly said, in statin intolerant people. We have a clear outcome study also with interim results out, and that is shown good results with bempedoic acid. So for statin intolerant, bempedoic is a good drug. Otherwise, statins still remain the gold standard.
Another question by same person, Dr. Jayesh Shah, and that is about type 1 diabetes and what will be the indication of statin in type 1 diabetes for primary prevention, particularly in type 1 with CKD.
Yes. So type 1 diabetes also, statins are definitely indicated if diabetes is more than 10 years duration, if there are no contraindications, and if the person is about the age of 30 for Indian standards, I think statins are definitely indicated. Childbearing woman or pregnant woman, we generally avoid statin therapy. Otherwise, male patients, obviously, they must be given. Even in CKD patients, because the CKD patients are actually more high risk for the cardiovascular disease, and their statins are definitely more strongly indicated. even for the type 1 diabetic patients. So it is not that young patients should not be given or type 1 should not be given. In type 1 also, there is strong evidence both for primary and secondary statins.
Thank you.
We would like to have expert comment from Kamal, Dr. Madhav Bhai, Bansi, regarding this.
No, what
about the
you said
bempedoic,
bempedoic acid is perfectly all right. That there are, you can't say there are no trials. Number one, and second, when would you use it? Nobody is going suggesting first use. It's always used in statin intolerance or statin ineffective cases. And what are the options? If you don't use that way, after ezetimibe, I think the only option is PCSK inhibitor. So if patient can afford, definitely that will be a choice ahead of bempedoic acid. But if that is not the case, then we have to use bempedoic acid. And barring few reservations of the uric acid or tendon, they are very safe. And we have started using it, and actually there are not many adverse outcomes. And response is also quite good. Come on.
Yeah, I completely agree. I think there are 4 series of trials. One of the largest outcome trial was Clear Outcome Trial, which is published in presented in the ACC 2023. It showed that in intolerant patients, you had reduced CV event rates, and this was in proportion with the LDL reduction. But you also had some other trials. Again, these are not CVOT trials, but they have been looked into patients with residual risk, or you can call FHF patients, familial hypercholesterolemia patients, who are already on statins and not achieving the goal. And when they were added bempedoic acid, the lipid lowering was much more significant. So you can combine, and there is no harm in holding that back. With regards to diabetes, again, I think already covered by Sanjay very well. I think statins do stand a very important role, even if for patients where there are signals of new onset of diabetes. We know that new onset of diabetes of 7%, which is higher, relatively also has 18% reduction of event rate. So this just, and then there is a meta-analysis which has looked at that new onset of diabetes is probably nothing but premature occurrence of the diabetes that was anyway to ensue. I'm just deviating from the topic, but I thought because we were talking about type 1 and type 2, I'll also touch upon NOD as well.
Dr. Jimit, any question from your side? Sandeep?
Yeah, no questions, but the comment that one question I'm always, so now they have come out with a combination of rosuvastatin with bempedoic acid, 40 milligram. So basically the aim of bempedoic acid is, to give it in a patient who is intolerant or who is not. So 40 milligram with 180, I'm somehow not convinced with that product. You can, use it differently rather than using the drug combined. Already we are used, the whole basic is that the patient is intolerant and you have to use that bempedoic acid. Or if it is not controlled, and then that time probably 40 with 180, and there is, the ezetimibe is again lost in that process. So
I completely agree. I think I also agree what you're trying to raise. I think more rational combination is bempedoic with ezetimibe rather than statin with bempedoic. So I would rather go with maybe a 10 milligram of rosuvastatin and then add a combination. If I have to add, go with bempedoic and ezetimibe rather than statin or bempedoic.
It's really surprising and shocking that why statin bempedoic acid combination is approved by DCG.
Yes, that is again.
It is not 40 milligram.
40 milligram, that too.
And ezetimibe was approved later. Ezetimibe bempedoic was on hold, and they could come up with the statin bempedoic ahead.
It is high time for Indian regulatory agencies to involve such organizations like RSSDI Cardiology Society in that process of giving approvals to such combinations, because then and then it will be justified combinations will be there in the market. Otherwise, any kind of 2 drugs combined together, pharma company will come.
Right.
Yes, Dr. Jimmy.
Sir, wanted to ask a question to Kamal Sharma, sir. We have seen the change in the thiazide-like diuretics being less preferred now. And we were studying, this was one of the reason for diabetic patients. So why it has changed now, sir?
Yeah, I think it's not much to do with the new onset of diabetes with thiazides or thiazide-like diuretics, but I think, including in our own paper in JAC, where we looked at the overall outcomes, and including in MRFIT trial where you had the crossover subgroup, that you found that the patients with thiazide-like diuretics actually had fewer event rates and prolonged survival as compared to patients on thiazide. Again, recently there is another editorial which is now countering this argument that this was a hype created to, sell the old wine which was not selling. So I think you'll have to take it with a pinch of salt. None of them was a prospective study. People have looked at those data retrospectively. MRFIT is a 1950s trial. People have looked at again retrospectively in patients who were in crossover group into 80s and found out they had lesser heart failure or more heart failure. Of course, the other advantage is that the lower dosages that you require with thiazide likes compared to thiazide diuretics may be one of the reasons why this switch is happening. Because in our paper that we published in JAC, the ABPM study, where we looked at the efficacy of 6.25 and 12.5 chlorthalidone versus 25 milligrams of hydrochlorothiazide, and it was as effective, or maybe sometimes we found it more effective. 6.25 was doing as 25, not 12.5. So I think when you have lesser side effect risk because you are much lower dosages, and you have also the advantage of being metabolically neutral, which is again touted as one of the advantage of indapamide, and to some extent with lower dosages of chlorthalidone, people tend to use this molecule with more often, and that's the reason I think pharma has also found a reason to sell a diuretic combination at much higher price than use it with hydrochlorothiazide. But between the two choices, I'm now feeling that with the SGLT2 coming in a big way, strong evidence emerging from MRA, I think diuretics themselves per se may be relegated to a different story and a different level. I usually tend to use MRAs more as a patient of resistant hypertension rather than use simple diuretics like thiazide or thiazide-like diuretics.
I think I will ask one last question to all the three panelists, and then we will conclude today's program. So, recently, ADA and SEC, they've come out with that change in hypertension definition with lowering that cutoff values. And almost all the guidelines, they are still like RSSDI, all other, they agree that 140, 90, above that is hypertension. So what do you think, that it is rather confusing, or we are moving in the right direction, or we are making it too much lower values for general public and diagnosing more and more people in hypertension? Dr. Kamal, first.
Yeah, so I think it's the J curve that we are talking. We are still we will probably go down as long as we can till you start actually get the upper border of the J. And I think a lot of issues are still there, the way we measure blood pressure, way we define hypertension. I think we need to resolve that first. I think the primary evaluation and scientific research would have to go how we are interpreting blood pressure. I think Sprint actually changed the ball game altogether. That says you can go up to 120 in elderly. That's so disastrous. A lot of criticism for Sprint trial as well, but that has actually pushed the ball. I mean, there was an article in a newspaper, which was an anti-pharma paper, which said that overnight the population of hypertensives in US became 50% higher. Till yesterday it was 140/90. Now you call it 120/80, and half of the population of US is now hypertensive. So this is it a gimmick by the pharma? That was the counter argument that was proposed. And I think we do have signals, especially in high CV risk group patients, like diabetics, like CKD patients, where the risk does go down when you go to below 130/80 or to 120/80. But then does it hold true for non-diabetic, healthy population? We don't know. Are these prospective trials? No. These are most of the trials which have looked at the mean blood pressure of a huge population and compared between the two subgroups and come out with a guideline that this is better than that. But then does not hold true for individual people, the individual person. And also in patients with Mockenberg degeneration, arteriosclerosis, the way you measure pressure may be so false. You may have a cuff reading of 150 and you go inside and check the central aortic pressure, it may be just 90. And you create a blood pressure situation of 120 in the cuff you might be creating hypoperfusion in the central organs, renal impairment, or stroke or ischemia. You never know. So I believe that the blood pressure assessment has to come from the central aortic pressure, which may be estimated based on augmentation index or pulse wave velocities. And rather than just sticking to office readings, I think we'll have to go back to home readings, which are better now. Even ABPMs are sometimes much better, as we know from a lot of studies again published, but surely not the office readings. I think what blood pressures doctors measure and then use that to treat hypertension will have to go away soon. I know a lot of white coat hypertensions. We all see. Sahib, ghare a chart kaade patient. When you tell them that you're 160, he brings you a chart. Date, time, su karta tha and ketlu hotu. And not a single reading will be more than 120. And then you ask which instrument, then he would tell you one ISI branded company. And then you ask again, is it 5-year-old? And he said, sir, I bought it only a couple of days back. So, I mean, you can't find out mistakes with the instruments or methodology. I think we'll have to change the approach. We define hypertension, what should be measured for hypertension, and how low we can go in patients who don't have comorbidities. But for sure, right now, evidence is pretty strong for diabetes, CKD, and ischemic heart disease that you'll have to keep it low, below surely 130/80, maybe aggressively explain them lifestyle up to for reaching 120/80. But below that, like sprint, I would still be taking that with a pinch of salt.
Yeah, I think Dr. Kamal has already talked for all of us in we also share the same. And especially when I was reading about this RSSDI trial, that why olmesartan was omitted, then I could read that because olmesartan brought down blood pressure so low, that same thing that he said about the J-cow, so it was counterproductive. So maybe that answers the question that we should go with the current guidelines of targeting the blood pressure to burn 120 and 130 systolic and not below 120 unless there is CKD. Thanks.
Anything to be added from your side? Please unmute, sir.
So nothing more to be added. I think 130/80 or below looks fair, but 140/90 RSSDI guidelines, I think 130/140, not much of a difference. New ADA guidelines 130/80, our RSSDI 140/90. The guidelines will keep on changing. We have to use common sense, as Dr. Kamal said. We have to rely upon the home blood pressure measurement rather than the office.
Right.
And I think individualization is the key as far as all these chronic diseases are concerned. You have to take all the factors into account before deciding any target for glucose or lipid or blood pressure. And each patient behaves differently. For some patient, if you keep their blood pressure 130/80, they are okay. It goes down, they develop postural giddiness and multiple other problems. So you have to do it in an individual level. I think with that, we conclude our session. We thank Dr. Kamal Sharma, Dr. Mahadev Desai, and Dr. Sanjeev Phatak for sparing their valuable time and for joining for this first session of Gujarat chapter of RSSDI related to RSSDI guidelines of 2022 and 2023. And I request all the participants who are joining there to become member of RSSDI, because a lot of learning material is there on the website. A lot of academic activities are being done. And at present, the lifetime membership is available at 6,000 rupees, and soon it will increase to 10,000 rupees. So this is an opportunity. We request all of you to join RSSDI. It is very simple. Log on to rssdi.in and fill the form online, upload your documents, pay online, and become member of RSSDI and get a lot of benefits from RSSDI website as well as online and offline activities. Now I will hand over to Dr. Sandeep Desai, Secretary, Gujarat Chapter of RSSDI, for vote of thanks.
Thank you, Pratap Bhai. And it was an excellent discussion, panel discussion, and all the three speakers were really very good. Thank you once again, Dr. Sanjeev Bhai, Dr. Mahadev Bhai, Dr. Kamal Sharma, and a lot of insights for hypertension and dyslipidemia also has been poured in. And of course, thank you, Dr. Pratap Bhai, to host the main event, and Dr. Bansi Sabu. I think he has gone, but he was the main author behind all these articles. And of course, Acmedix, who has given the academic support, and all the delegates who have joined in and got some insights from all this discussion, of course. Thank you, everyone.
Thank you.
On behalf of Acmedix, I thank all faculty members for joining such a nice program. And also I thank to all delegates for joining for this program. Acmedix is always a front runner for all academic activities, and we will be in future also support all academic activities. Acmedix is operating in a unique way with a lot of economy with quality, and we will continue to do in the future. Thank you so much, and good night to everyone. Thank you so much.
Good night. Bye-bye.
Bye.
Good night. Bye-bye.
Good night.
Thank you. Good night.